Hello, everyone, and thank you for joining today's UMB ICTR Enrichment Seminar. I have a slide up that's a bit of housekeeping. Before we get started, just a reminder that this session is recorded and will be posted to the ICTR website in our education section for your reference. We are reserving the last 10 to 15 minutes for questions and ask that you post them in the chat or feel free to use the Q&A feature. If it's something that you would like to have addressed right away, I'll keep monitoring the chat and we can pause so that Joan can, address any questions you might have. Finally, as you leave this session, you will be redirected to a survey. We value your input for future presentations, so please take a moment and share your thoughts with us. And now I have the tremendous honor to introduce our guest speaker, Dr. Joan Carpenter. Dr. Carpenter is an associate professor at our School of Nursing in the Department of Organizational Systems and Adult Health, and she is also our Associate Director of the ICTR's Community and Collaboration Core. Her research focuses on palliative care, geriatrics, and post-acute and long-term care settings. Dr. Carpenter was awarded one of our first UMB ICTR Community Engaged Research Partnership Development Funding Awards. This award supported the development of an academic community partnership to study palliative care in Maryland nursing homes. In her presentation, Dr. Carpenter will share with you the impressive results and pathways forged through this incredible work in her presentation, Strengthening Palliative Care in Nursing Homes, Insights from a Community Engaged Research Partnership. Welcome, Dr. Carpenter.
Thank you so much. I appreciate being here today. I think I need to be given sharing privileges to share my slides. There we go. Okay, let me just get this up. Can everyone see my screen?
Yes.
Yes, great, great. Well, thank you so much again for inviting me to share the experiences that I had with my team during the voucher program. As you mentioned, we're going to talk today about an academic practice partnership to build palliative care capacity in nursing homes. And we started in Maryland. And interestingly enough, the national organization I worked with wanted to extend this work in Rhode Island and did that on their own with another colleague. And I can talk a little bit about that as well. For purposes of definitions, I'm going to use the word, right now we're talking about nursing homes. My organizational partner really uses the word post-acute and long-term care because they provide that both types of services to the patients and the residents that receive care in their facilities. Post-acute care is often delivered after a hospital stay for a short period of time when someone may need some extra medical care, nursing care, and rehabilitation. Whereas long-term care is what we think about in nursing homes where people are living there for an extended period of time, often months, years. And so I'm going to start just by telling you over the next 40 minutes or so, we'll talk about the Partnership Development Voucher Program, our partnership model, the framework that we used, our approach and methods. Talk a little bit about our findings and then the implications and next steps. And we'll leave some time for questions at the end, which I often think is some of the best part of presentations because so many good ideas come from all the folks that join and think about the information that we share together during the presentation. So I'm going to start by just familiarizing everybody with the Community Engaged Research Partnership Voucher. And really, this program, and these are quotes directly from the application, it's specifically for developing a successful and sustainable community partnership in the Maryland and DC area. And the purpose is to prepare for a future competitive proposal, either through ICTR or another extramural type grant application. The funds really are focused on facilitating formal and informal meetings with the partners to identify shared goals, priorities, research interests, and sharing resources and funding. It also facilitates open dialogue and bidirectional learning around the challenges and the opportunities to address community health needs. And the community is any population of interest that investigators work with. It also helps your a researcher to identify the community partners that will help to engage the community and define a research question. It can build research capacity for the community partners, such as IRB training or training on research design and methods. It also builds the capacity of the academic partner in principles of community engagement. And then also, we really, in this, the funding mechanism, strive to identify the needs of traditionally underserved or marginalized or minoritized populations. So, just a brief overview of the requirements. This is required documents for the application. There's really not a lot that is demanded from the researcher, except that you think through your proposed approach very carefully and how you're going to engage with the community partner, your plan for a future grant, and what's going to be the impact on the community. And again, and there is an abstract, a budget, and a budget justification. I applied for a little bit less than $10,000 and included quotes for services and fees. And I'm happy to talk about how we use the funding for the project. My timeline was 12 months, but this has changed. Now we're allowing for 18 months. And I will tell you, I did need to extend the time past 12 months of the work that I was doing because of some of the delays in working with the group, the Community Advisory Board, and our partner. Make sure we got the work done right. So, why palliative care and post-acute and long-term care matters? Um, Post-acute and long-term care residents and patients live with multimorbidity and high symptom burden. Many are also living with cognitive impairment, including dementia. They can experience frequent transitions, hospitalizations. There's often major stressors on the families and the staff that are caring for these residents and patients. Palliative care helps to align care with goals and it improves comfort. But the access to it in post-acute and long-term care settings is uneven and it can be delayed as well. So the rationale for our partnership approach was to leverage complementary strengths between the post-acute long-term care organization that provides reach, operational insight, and implementation pathways, and then the School of Nursing, which contributed research infrastructure and training expertise. So together, our goal was to build sustainable capacity, not just isolated interventions. As I mentioned, these settings are complex too. There's a lot of staff turnover that needs to be addressed. And nursing homes and post-acute long-term care settings serve as institutions that provide medical care. So people may be receiving IV, intravenous fluids and different types of therapies. They also serve as social settings. Everyone can think about bingo at the nursing home and different activities that occur throughout the day. They also are people's homes. This is where people eat their meal, sleep, live, eat their meals, and carry out daily activities. So there's a lot that is being asked of the staff that is delivering care in nursing homes, and that can really lead to additional complexity. So, as I mentioned, our partner organization was a national post-acute long-term care organization and an academic school of nursing. And we aligned ourselves on a shared mission to improve comfort-oriented person and family-centered care in the post-acute long-term care setting. What I also want to share is because this was a national organization, they have facilities in Maryland, but also obviously other states. So that national reach was really important as well. We also had done previous work with this organization. I had partnered with one of the chief clinical officers on some previous quality improvement projects that they had initiated on their own. So we had a baseline relationship, which was extremely helpful to build off of. And I do see there was a something in the chat, but I'm not able to get to it. Wanda, is there a question in the chat that I should answer?
I do not see anything in the chat.
Okay.
I
Okay, I
believe it
see.
was just Wanda putting in the link to the CENR Partnership Development Voucher Program.
Perfect. Perfect. Thank you for doing that. And I want to encourage people to ask questions in the chat throughout if there's anything that they would like to discuss about the project. So, I do want to take a moment to talk about the fact that many researchers encounter obstacles in community-led research. And oftentimes this can include distrust, time constraints, limited resources. And trust among community members and academic researchers is crucial for success. And trust can be lost if the researchers do not acknowledge their partner's historical context of the research or don't recognize that partners are the experts regarding their community, and their priorities are as important as those of the researchers. So, inadequate time and resources, along with inequities, can compromise the needs of the community and weaken the relationship and project sustainability. So, community engaged research principles guided us in this project. We were able to engage our key partners early and often. We shared decision making power. We ensured there was mutual benefit and trust. And we planned for bidirectional learning. We learned from our organizational partner, and they learned from us. This helped us to design a project at the end, a research project at the end of this, at the voucher program that was acceptable, feasible, and sustainable in a real world setting. Community engaged research involves a functional partnership among the researchers, among caregivers, patients, clinicians, and other key partners along the research continuum. And that is from study planning to data collection to disseminating results. And community engaged research supports individuals and communities seeking a lead role in identifying and solving their most pressing health problems. So this is a busy slide, and I'm going to break this down into each step that we followed during our project. We adapted a comparative effectiveness research lens for implementation, and we chose strategies that would work in routine settings, and we measured outcomes that were important to our key partners. Now, I'll dive into this a little bit more as I go through the next slides. But this framework really emphasized fit, feasibility, and continuous learning with our partners. I also am showing you the timeline of how we operationalized this conceptual framework. So all of these, for lack of a better word, steps or tasks that we were engaged in were mapped out into a timeline over 1 year, and we broke it down into quarters. You can see in this timeline that we had continuous meetings with our community advisory board, at least monthly, where we had specific tasks that we wanted to complete during each of those board meetings. And as I talk more about the Community Advisory Board, I'll let you know that we did recruit researchers, educators, and practitioners. And these are leaders from the post-acute long-term care organization, bedside clinicians, as well as uh, primary care providers. And the Community Advisory Board grounded this project in the lived operational realities that helped us balance rigor with practicality. The roles of the Community Advisory Board were to co-develop the project, to refine the question we were asking, to advise on any recruitment that we needed to do, to interpret initial findings, prioritize next steps. So this can be applied to really a researcher in any setting that they are conducting their work in. We really sought to increase the relevance of the work that we were doing by encouraging and responding to the needs of the organization. So, the first step in this that I'm going to review is the topic solicitation. So, through an ongoing series of structured discussions, our advisory board and project team worked together to identify the most pressing priorities for improving palliative care in post-acute and long-term care settings, particularly within our partner organization. Our discussions focused on aligning the organization's operational goals with the academic team's expertise in serious illness care, and to ensure that the project addressed the issues that were most relevant to the residents and patients in the post-acute long-term care setting, the families of those patients and residents, and the staff working in the facilities. The community advisory board members shared firsthand insights about workflow in the setting, the challenges that they experienced, where they thought there might be some gaps in staff training on palliative care, and communication barriers that seemed to affect the delivery of palliative care. So, using their input that was gathered through this facilitated dialogue and feedback, it shaped the selection of the topic to ensure that it reflected relative, real world priorities and opportunities for what could be meaningful change within the partner organization. After topic solicitation, the Community Advisory Board had iterative discussions to prioritize the focus area using agreed upon relevance to improving resident and family outcomes, aligning them with our organizational goals, and looking at the potential for enhancing staff competence in palliative care. There were three interrelated priorities that emerged. The first was assessing palliative care attitudes and knowledge among the staff. We identified that we needed to understand what was the baseline staff attitude and knowledge about palliative care before we could make any sort of change. We also together recognized that the high prevalence of cognitive impairment and dementia in post-acute and long-term care settings is really important to better understand where is the knowledge and how comfortable is the staff with family partnerships and care planning for those who are living with dementia, many people living with dementia are not able to make decisions about their care. So how comfortable was the staff feeling in partnering with families? And then the third agreed upon goal was to really understand what a research agenda would look like to support sustainable palliative care integration and quality improvement in their setting. And sustainability is extremely important because as researchers, we tend to come into our settings, do our work, and leave. And we really focused on the fact that whatever we were going to propose to do in this setting needed to be sustained by the organization itself. So it needed to be doable in the real world. So then we came to framing the question. So we worked together to collaboratively frame a key guiding questions to structure the assessment and improvement efforts. And as I mentioned, when we talked about prioritization, we wanted to assess staff attitudes and knowledge, explore dementia knowledge, and staff family partnerships. So, in framing the question, we decided that we wanted to understand, as I mentioned, their attitudes and knowledge gaps, how dementia care could be strengthened to improve outcomes, and then how the facilities would receive a program to address these types of knowledge gaps, and what would be a doable intervention in their setting. So we decided to distribute a needs assessment survey, and this was a cross-sectional needs assessment that was delivered at one time point, and we used validated instruments, including a palliative care knowledge survey, an advanced dementia knowledge assessment scale, and a staff family partnership instrument. Again, directly informed by the question that we were asking. The advisory board provided iterative feedback on this survey to ensure it was clear, that it was feasible, and it aligned with daily operations. And what I will tell you is that several of the advisory board members had piloted the survey, and we went through probably 3 or 4 iterations of reducing the number of questions, realizing that staff are busy in these settings. And if we really wanted to get at the information that we needed, this had to be a 5 to 10 minute survey. And we also recognized that we needed to compensate the staff for the time that they spent doing the survey. So we were able to engage with the leadership in the individual 5 nursing homes and deliver the survey to anywhere between 18 to 25 staff members on different shifts in the nursing facilities. Originally, we had planned as the researchers to go into the nursing facilities and collect the surveys. But upon feedback from the advisory board, they preferred to identify a champion within each of the facilities that worked for the facility and to come into the facility on their day off or after hours to collect surveys from the staff members. And they were compensated for their time too. So again, we were constantly making adjustments and modifications in our approach throughout this project based on the feedback of our organizational partner. We were able to collect the surveys on tablets that we distributed to the champion in each of the facilities, and they were able to the staff were able to answer the questions in the survey directly on the tablet, so it was collected through Qualtrics. We collected these surveys over a 4 month time frame. I really have an incredible team who all worked together to make sure that we could get the tablet to the champion, touch base with them to troubleshoot any issues that they had with connectivity or with the survey, to ensure that we were getting the surveys completed and accurate data, as well as making sure that each of the participants were and I'm not saying, I don't want to say research participants. This was not research. This was preparatory for research work. So each of the staff members who completed a survey were compensated for their time. And so in the end, we had 111 staff who completed the survey across the 5 facilities. And we, together with our advisory board, examine the findings and contextualize their meaning to inform our next steps. So overall, we found that the staff had positive attitudes toward palliative care. They recognized the value of palliative approaches for residents and families, and they really expressed an interest in additional training. Part of our survey as well at the end, whenever staff were done with the survey, they were able to go to an additional survey if they were interested in serving as a palliative care champion in the future in their facility, because we had initially, with our advisory board, thought it would be a really good approach to see how many people within each facility expressed interest in being a palliative champion so that they may stand out as someone who could lead the effort in that facility for a future intervention. Again, the staff showed support for comfort-focused care, and they showed an interest in additional training, which we thought was really important. Identified knowledge gaps. So these emerged around advanced dementia care and non-pain symptoms such as dyspnea or shortness of breath, anxiety, behavioral expressions. And the staff requested practical tools for assessment and stepwise management aligned with residents and patients' goals of care. The symptom management challenges included under-recognition of pain, especially in dementia, limited non-pharmacologic strategies, and an uncertainty about how to titrate medications and pathways to do that. And we recognized that standardized tools and algorithms could support more consistent practice. So we concluded from these findings that investing in workforce development and system level support through internal capacity building would significantly, or had the potential to significantly improve the delivery of high quality palliative care. We also importantly identified barriers in our survey, and these revolved around limited staffing levels. The staff reported high workload and time constraints. There was limited formal education on palliative care that at onboarding, they didn't always receive information and training on palliative care, and there were few continuing education options. One of the biggest challenges of delivering trainings in nursing homes in post-acute long-term care settings is that the staff is so busy taking care, and this is their job, taking care of the residents and patients, that taking time away from that important work for a training is really difficult. So we had to think through how we could design a program that was realistic and practical for these staff members. We also learned about some team communication gaps, that especially around care transitions, and how we could how we could help staff better engage family in communication. So from these knowledge gaps and from understanding barriers a little bit better, we came up with three priority areas for next steps. The first priority area was skill building, and this is focusing on core competencies in palliative care, such as assessment, communication, and aligning care with goals. Certainly, dementia-specific care is important, and some practical symptom assessment and management tools. And we recognize that from this work that it was important to build the skills across all of the different roles within the post-acute and long-term care setting. And that means those who are working as nursing assistants, licensed practical nurses, registered nurses, dietitians, activities coordinators, all of these team members work together as what we call an interdisciplinary team to deliver care. And it would be important to make sure that everyone receives some core competency in palliative care. Our second priority area focused on team communication. And as I just mentioned, interdisciplinary collaboration is very important. Um, we wanted to, think about how we could promote care discussions that would promote goal concordant care. That means that people are receiving the treatments that align with their care goals. That there might be a role here for standardized communication tools, and this would be across shifts and disciplines. And our third priority area is on family-centered care. That ongoing family communication is very important, especially for those living with cognitive impairment and dementia. And so we needed to normalize, have an approach that normalized early, ongoing conversations that could support advanced care planning and provide anticipatory guidance for common trajectories for people living with serious illness in this setting. I mean, how do we best support patients and residents and their families during decline? So this is a lot of work that we were putting ahead of ourselves. And in addition, I guess in parallel with identifying these priorities, we also recognized that there was important organizational strategies we had to keep in mind, that leadership it had to be engaged throughout this whole process, and we were able to keep leadership involved in our community advisory board. We needed to make sure that as we moved forward, that policies aligned with the work that we were proposing to do in the facilities. Thinking too about, how do we sustain, as I mentioned, comfort-oriented care? So what are we going to do to make sure that the facility itself can sustain the project or the implementation of a project that we propose? So these are the next two steps where around dissemination and translation, which is incredibly important. The dissemination of this project has been ongoing and collaborative with our advisory board to ensure that the approach and the findings are accessible and actionable. We did share the survey results in plain language summaries with our advisory board, and one of the advisory board members in a leadership role was then taking those results, those survey findings, back to the individual nursing facilities. A member of the Community Advisory Board presented the partnership development approach at a national conference last year and actually was received an award for her work. Our survey results directly informed, importantly, the co-design of what we decided would be a quality improvement project. And this best met the needs of the organization. This was submitted for funding through what's called a civil monetary penalty grant fund within the state. And these are federal funds that nursing facilities pay when they receive citations for care. And then the money is reinvested back into the facilities. So this is a formal mechanism in the state of Maryland and every state to ensure that the funds are reinvested back into the nursing facilities that have paid into it. The overarching goal of this proposed 3-year project is to deliver a comprehensive, evidence-based education and training program for the post-acute and long-term care staff to improve their ability to deliver high-quality palliative care. And so, to achieve the goals of the project, we are planning to identify 2 to 4 palliative care champions at each of the facilities and engage them in a palliative care leadership role. So we already have folks who have identified themselves as interested in being a champion. And in this role, they will have memberships to a national hospice and palliative care organization. They will have access to educational resources within that organization. And then we will help prepare them if they are interested in certification in hospice and palliative care within their respective discipline. We will deliver a train the trainer program to the champions who will then take it back to their facilities because this was important to our organizational partner that the facilities themselves were delivering education to their staff members. And then that through that trainer program, they would engage their staff in quarterly education programs that were bite-sized, 15 minutes, very, very brief trainings. But then that champion always serves as the expert in that facility for staff members who may have additional questions or request additional materials. We also part of the proposal is to develop a sustainability plan for this education and training program so that it exists beyond the 3-year period. We'll be tracking benchmarks of the project, which is going to include staff knowledge and attitudes, as well as family perceptions of care in the facility, because that too is important to our organizational partners as our families' experiences of care improved with a palliative care program. In parallel with this particular quality improvement project, we have developed a large grant proposal to look at resident and family outcomes of a primary palliative care program that's being delivered nationally within this organization. We would not involve the 5 facilities in Maryland in that project. So, a little bit about lessons learned. In this project, we established an infrastructure, we built a partnership governance, we had key partner engagement, and we were able to assess baseline needs, do a baseline needs assessment. These elements were all really needed in order to create the quality improvement project that we did. Preparing for research and quality improvement is so important. Preparing for these types of project, we were able to assess site readiness, select feasible implementation strategies such as champions and train the trainer education programs, and define practical outcome measures. So many key factors must be considered when you're developing community partnerships to effectively develop community engaged research. There has to be respectful accommodation of the concerns of the community members and really meticulous thought and preparation when leading these types of projects. I want to emphasize that the voucher program demonstrates that focused time and attention to enhancing community engaged research skills and competencies really strengthens the researcher's ability to constructively partner with their communities of interest. Implications, as I mentioned before, that these methods really have real world relevance. This has provided foundation for future quality improvement and research, clinical trials, and there is incredible value in the funding for preparatory work for research. I do want to take a moment and acknowledge the post-acute and long-term care partners who served on the Community Advisory Board and the staff who participated in the surveys that helped us to better understand what their needs were, and as well as the team that I work with here at the university, who I really could not accomplish all that our team does without. And as I mentioned earlier, once we did this work in Maryland, this national organization wanted to do very similar work in Rhode Island. And so we were able to do that with some other funds that were available. So it's an example too of how once you build a relationship with your community partner and they see what you can do locally, that there could potentially be national reach. And that concludes what I have prepared for today. I really thank you for your time and encourage any discussion and questions that you might have around, the setting that you work in, organizational supports that you're curious about, how you could get started in doing something like this within your own research program. So with that, I'm going to stop sharing and ask if there's any discussion or questions.
Hi, Dr. Carpenter. Sorry, my clicking on the video to show myself seems to be a delay, and I'm too impatient to where I keep clicking on it, so I'm going in and out. So with that, I see that we still have quite a few participants that are online, and we really do welcome any comments you want to add to the chat. If you would like an opportunity to speak, let me know, and we can certainly give you that opportunity. And we're really open for some really nice discussion about the success of this work that you have done, Dr. Carpenter. Really fascinating and something that I think that we all consider, especially with our aging parents, or if we are the aging parents. So, oh, very great. Thank you, Lynn.
Yeah, so I think, this is, I'm just, the reason I'm thinking about when I approached the voucher program, I had to really think carefully about like, does this apply to me? Because I always think about the community as, those who are living in personal residences, their homes, and community organizations that, made the senior centers or faith-based communities. And I had when I saw the voucher program, I thought this is a really great mechanism for me in creating this partnership because nursing homes and post-acute long-term care settings are really challenging. This particular organization had it participated in research projects before, but researchers hadn't always been as collaborative, and that can leave a bad taste in communities' mouths. I mean, that can really lead them feeling like they may not want to partner again. And I think really in taking the time and thinking through what this would look like, even though, we all are pressed for time, we're all thinking about getting our grants, getting our publications, but really investing in the infrastructure for a long-lasting partnership was the motivation for this work. And when I applied for the voucher, the organization provided a letter of support. And they also were very invested in what we could build together. And I think that's so important. And I can't say enough about preparatory for research work like this in engaging the community.
I think that those in the community that have experienced the helicopter type of research that has happened, where researchers come in, they collect information, they leave, they don't really share what's happened, and they really don't include the community in that research and understand what the community's priorities are. And certainly, we're really excited about the CENR Partnership Development Voucher and the impact it can have in demonstrating that the community is important wherever that community is, whether it's in a long-term care facility, or it's in West Baltimore in general, letting them know that we do want to know what your concerns are, what research is important to you, how do you think it should be conducted, and doing that preparatory work is important. Otherwise, you spend a lot of resources uh, going down a pipeline that is not relevant to the community.
Hmm. Hmm. And they're the experts in their community.
Yeah.
We think we're we think we're the experts. They are the experts in their community. So it's important to remember. Any questions, comments? Anyone have experience, good and maybe not so good, in attempts to lessons learned?
I think a lot of what you've presented can definitely be translatable to, or the approach to other areas in the community, whether it's schools, whether it's any type of service-oriented um, service,
Hmm.
um, understanding the community and who the partnerships are, or how to develop those partnerships. And your approach was so systematic and so thorough.
Hmm. Hmm. And very valued by the organization. They're busy people. They're very busy people. They're in and out of meetings. We had the vice president for population health was on our advisory board. And that was so important to get the buy-in of the facilities at the local level, because that person was able to have direct communication about us wanting to come in and survey, and also told us they don't want you in there. They want to do it themselves. And so we had to go through actually iterations with the our approach, as I mentioned, and we had originally planned to pay the community partner as part of the funding, to for their time, but it became so challenging to create those agreements. That's when we had to redesign and say, okay, we will do the compensation to the individual survey participants, because what we wanted to do was compensate each of the facilities themselves for the work they were doing, and they could decide how to use the funds. But they decided that that wasn't going to work for them. It was actually going to create more work for them. So they preferred that we did it. Um, Also, starting from the beginning, saying, okay, we're going to build this, we're going to build this partnership. What are the questions that you have? What do you think are the gaps that we need to be, better assessing so that we can design an intervention, a project that's going to work? And so again, it's around pre-implementation as well, understanding, before organizational readiness, before you move into that setting, what do you need to be prepared for?
Joe, may I ask a question? So you obviously have a very thoughtful and successful approach, um, and you're focusing on palliative care and nursing homes. So how applicable is your approach and generalizable? So say you wanted to go into a community where chronic kidney disease and diabetes, and the individuals ranged from late 20s to early 50s. Um, do the same principles apply? Do you have to be able to customize your your approach? What because I another thing that worries me is that community engaged research is very sophisticated, and you have subspecialists. So, what's your thoughts?
Well, I think you bring up a really good point. I mean, is this applicable to any setting? And I think it can be. I think that knowing who you want to engage with, knowing that community, and then understanding the people who are a part of that community and can give you good feedback. So right now I'm recruiting for a community advisory board for a large RO1. And we don't want people to come to our community advisory board and tell us what we want to hear. We want them to come and tell us, what are we not getting right? What are we missing? What are we? So having that kind of that vocal person who's going to give you honest and frank feedback is important. So, we right now are interviewing people. I mean, we're meeting with them and meeting them to understand how do they approach conversations about the topic of interest, the topic that we're interested in. So I think that's important. But again, it's also being invested in being authentic. Once you're authentic with communities and they know that you're there and that you're not going to walk away, that you're going to stay, then I think it's helpful. But I think too, when you talk about that particular community of interest, my guess is that you are a researcher, so that you know those folks, you know what they're experiencing, and the local. If it's like you said, West Baltimore, or if it's rural Maryland, spending time and engaging those people as they are the experts is important. Um, and pulling in anybody who's a trusted community member, a trusted healthcare provider that works with them, is important as well.
Thanks, Joe.
Sure, sure. That's a great question. I think it's just it's really thinking differently when you're doing community engagement and recognizing that, as I mentioned before, like we're the experts, but we can't be the experts in everything. Communities are the experts in their own health problems and their solutions. With Yeah.
I just have one other question, Joan. How do you identify a community partner that really is representative of the community? How can you how do you select that person? How do you know it's someone that the community feels comfortable with? Identifying that person as, a representative for them.
Mm-hmm. Mm-hmm. That's a really good question. Because this project was one of the first that I had convened a community advisory board to develop our next steps. And what I did with them is I approached their leadership, who I'd had a relationship with, and said, if we're going to do this in Maryland, who do you suggest be a part of the community advisory board? At this point, we did not have residents and families on this particular community advisory board because it was partners, it was clinicians, and it was those who were working in the long-term care setting, because that was our target. Our purpose was to improve or to address the staff delivery of palliative care. Family outcomes are really important, and that's why we're working them into the evaluation of the project we're proposing. But at this point, we didn't have residents or families, post-acute long-term care residents or their family members on this board. So that said, I relied on the organization knowing who were the trusted people within their organization that could serve on this board and could give us the feedback that we were looking for. In the project that I'm currently recruiting community advisors for, we have just some criteria, like very minimal criteria, that they are a family caregiver of a person who is lived in the nursing home, who has been living with dementia in a nursing home. And I think getting to know them and kind of what their day-to-day life is like caring for that person is important. How involved they were for us at least, in the nursing home, being in the nursing home. So I think it's just those little, I think, Wanda, for every project, it's going to be different about what your goals are in learning about through that community advisory board. Um, if it's an area, to me, if it's a geographic area that you're not familiar with, it's spending some time getting to know who's who in that area. And as I mentioned with Dr. Davis, getting input from the members of that community about who they would recommend, who they may know, and then having discussions with those folks.
Thank you for that. That's always been a question in the back of my mind is how do you choose
And I will tell you on that board that on this project that I'm talking about, we did identify two people, one of which was is with a advocacy organization, a national advocacy organization, who was unable to attend and participate. So that person, didn't continue. Um, and then we had another external clinician from the organization that we identified, and that person wasn't able. So we definitely, when you want people showing up to the meetings and giving you feedback. And so that's just as important is making sure that people and we did compensate the advisory board as well that were not school nursing participants. So anybody that was in the community participating uh, was compensated for their time for the meetings. Any other questions or comments?
It looks like we do have a question. Do you have suggestions on where to find national guidelines regarding what should be standard practice for primary palliative care providers?
Mm. So the National Consensus Project for Quality Palliative Care is a great document. It's actually being updated right now. We're convening this year to update the National Consensus Project, and I can put the title of it. It's the last one was published in 2018, but these are clinical practice guidelines that we recommend for palliative care. Now there are a lot of them, and there's 8 domains. So let me see if I can put this in the chat. Yeah, there we go. So I just went ahead and put that in the chat. I thought you were going to ask about national guidelines for community engagement, but PCORI has such great resources on community engagement. I highly recommend if anyone's looking for guidance that they also, consider visiting PCORI for information. Oh, good. Yeah, I see, Rachel, you. I just sent it to the hosts and panelists. Thanks, Rachel, for putting that out there. Um, there's a lot of debate about primary and specialty palliative care. We know there's not enough specialists to meet the needs of all the people who are would benefit from palliative care. And so some of my work has really focused on how do we enhance the skill set of primary care providers and those providing care to those living with serious illness day in and day out. How do we make sure that they have the capacity and the skills to deliver that care? So hopefully that National Consensus Project guideline will help you. I know we're on everybody's lunch hour and we're up against the top of the hour.
I just
Um,
added the link to the PCORI website as well in case there's someone who's interested in that. And yes, I don't see any other questions. And with that, I think that we can let everyone go and enjoy the rest of this lunch period. And thank you so much for attending. And thank you so much, Dr. Carpenter, for this presentation and valuable information. Thank you. Bye, everyone.
Bye-bye. Thanks so much. Have a great day.